So we all know that PCOS is the most common endocrine disorder among women, and it affects 5 to 15% of the reproductive female population. We also know that hyperinsulinemia is always present. Obesity, which was earlier thought to be mandatory, now is seen in about 80% of women with PCOS, and obesity exacerbates the metabolic risk associated with hyperinsulinemia. 50% seek fertility services, but 70% of PCOS women remain undiagnosed because of their ignorance until such time when they seek assistance with conception. So it is essentially a heterogeneous disorder, a triad: symptoms and signs of androgen excess, hirsutism, male pattern baldness, and or hyperandrogenemia, ovarian dysfunction, oligo-ovulation, polycystic ovarian morphology, and it is essentially a diagnosis of exclusion. We have to exclude thyroid disorders, hyperlipidemia, Cushing's syndrome, androgen secreting neoplasms, and non-classic congenital adrenal hyperplasia. So we essentially follow the Rotterdam diagnostic criteria, which requires 2 of the 3: oligo or anovulation, clinical or biochemical signs of hyperandrogenism. Clinical can be acne, can be hirsutism, can be male pattern baldness. Biochemical, of course, hyperandrogenemia seen in blood test, and polycystic ovaries, and exclusion of other etiologies. This PCOS seems to start in the womb and end in the tomb only. The female offspring exposed in utero to high levels of androgen may be predisposed to PCOS following puberty. So this hyperandrogenism is a result of raised maternal androgen as seen in mothers with PCOS, or from the fetal adrenal or ovary, or from a dysfunctional placenta. A review of 82 studies have shown that hyperandrogenic intrauterine environment that programs the genes concerned with ovarian steroidogenesis, insulin metabolism, gonadotropin secretion, and ovarian follicle development. This results in PCOS in adult life. So we know PCOS has multiple etiology. It has genetic, and there are a lot of gene mutations, and environmental also is very important. Metabolic is very, very important, obesity, and epigenetic. So epigenetic actually means they are heritable phenotypes, but they do not affect the DNA sequence. But then there can be alteration of genetic material by altered DNA methylation or telomere shortening. And the most important thing is placental alteration, which we never thought of earlier. So this is really a very nice review article by Filippo. The same thing is fetal hyperexposure to androgens, a cause of PCOS. So we know about the maternal environment. We know about the fetal environment. There is genetic predisposition because the mother has, then glucose increased, androgen increased, all that. But then we also understand the kisspeptin system is also affected even in the fetus. Kisspeptin is actually a peptide which is related to KIS1 gene, and this is actually secreted in the hypothalamus. This has an impact on the reproduction. So even in utero, the KIS system seems to be altered, and there are possible autism spectrum disorders because of all these things. And in the placenta, P450 aromatase activity is decreased. This is a very important one, 3-beta HBS1 activity. So all these things probably determine PCOS to a certain extent. So in that pregnancy also, there's GDM, preeclampsia, PIH, preterm delivery, miscarriages, and the baby is also not spared. It has hypoglycemia and even perinatal death. So fetal programming of PCOS starts in utero. The androgenic environment is very, very important, and the insufficient intrauterine nutritional environment. This is similar to the Barker's hypothesis, where nutrient deficiency in utero resulted in excess in the baby, post utero. So what about the genetic effect? So we know PCOS is a complex multigenic disorder where predisposing genetic variants interact with strong environmental influences. And 10% of PCOS are said to be heritable. In Han Chinese population, susceptibility loci were found on 2p and 9q, so chromosome 2 and 9. But in Europeans, only it was found on chromosome 3. And what about the pathophysiology? So there are a lot of positive things which we have identified about PCOS, but these are all loose ends only. Finally, we have to tie it up that still has not occurred yet. So there is an insulin receptor dysfunction. More than receptor dysfunction, it is a post-receptor dysfunction. So we have increased serine phosphorylation of the post-receptor, and because of this, insulin signal transduction downside is affected. There is also, because of that, what happens is pancreas secretes a lot of insulin. So this results in increased DHEAs in adrenals. In pituitary, it causes increased LH. And in the stroma of the ovaries, the theca cells produce androgen. And in follicles, there is decreased aromatization of androgens by granulosa cell. So intra-ovarian androgen increases. So ultimately, because of all these things, anovulation occurs. And we see that the hypothalamus is also affected. The GnRH pulses have to be slow to have a beneficial effect on the FSH, and have to be fast if they want to have an effect on the LH. Here the impulses are quite fast, so LH seems to be high and FSH seems to be a bit low. So there are a lot of environmental factors which play a role in the early stages by converting a predisposed genotype to the phenotypic expression of PCOS. It can be high fat, low fiber diet, sedentary lifestyle, smoking, alcohol consumption, and even there are a lot of endocrine disrupting chemicals in the environment, particularly bisphenol A. This can also contribute to PCOS. Bisphenol A is also obesogenic. So all these plastic items probably contribute more to PCOS. So we have 4 phenotypes in PCOS. So the phenotype A is the frank one, where we have all the 3 components: hyperandrogenism, chronic anovulation, and PCOS. It is about 40 to 70%. The most important thing is it has known long-term risks. The classic one, that is the B, that also has hyperandrogenism, chronic anovulation, and PCO morphology might be there, might not be there, but hyperandrogenism and chronic anovulation are present, and the incidence about 7 to 40%, long-term risks are known. The ovulatory one, that is a phenotype C, here she ovulates regularly, hyperandrogenism is present, PCO morphology is present, prevalence is 7 to 20%, but long-term risks are unknown. So mild variety, phenotype D, where chronic anovulation is there, polycystic ovarian morphology is there, hyperandrogenism may or may not be present, long-term risks are unknown. So even though she has PCOS, if she belongs to phenotype C and D, she does not develop long-term risk. And what about ethnic variation? PCOS actually manifests differently in different ethnicities. So in Africans, they have more higher BMI, metabolic features. But for us South Asians, central adiposity, type 2 diabetes mellitus can occur, metabolic risks are there, and acanthosis nigricans is usually seen which tells us that insulin resistance is high. So what are the main concerns? So the one is anovulation. So what happens when anovulation is there? Menstrual irregularity can be there, infertility, endometrial hyperplasia which can progress to cancer, and fibroids also. So they say the association nearly 65% because of estrogen excess. Then we have the androgen excess, so which is manifested in the form of acne, scalp hair loss, hirsutism, and this can also to a certain extent lead on to depression. And metabolic dysfunction in the form of obesity, type 2 diabetes mellitus, dyslipidemia, sleep apnea, and non-alcoholic steatotic hepatitis. So how do we diagnose adolescent PCOS? So we have lot of criteria, but then let us go to the Pediatric Endocrine Society criteria 2015. So here they talk about only two things. One is the abnormal uterine bleeding pattern, abnormal for age or gynecological age, and persistent symptoms for 1 to 2 years, and then the evidence of hyperandrogenism. Persistent testosterone elevation and hirsutism can be there. So that is, or they can have moderate to severe inflammatory acne vulgaris. So no mention about polycystic ovary in adolescent PCOS as per Pediatric Endocrine Society criteria. So why is it so? The functional variations in the hypothalamic pituitary ovarian axis during normal puberty, they mimic features of PCOS. So signs and symptoms of PCOS overlap the physiologic changes of puberty. So in adolescence, androgen excess and ovulatory dysfunction more than 2 years post-menarche is diagnostic of PCOS, so both would do. But then ultrasound is done only after 8 years of gynecological age, that is 8 years of attaining menarche. But probably it can be done earlier when the hirsutism is very marked, or when the androgens are very high, to rule out ovarian tumors. And in adults, 2 of the 3, androgen excess, ovulatory dysfunction, or polycystic ovarian morphology should be present. So ultrasound, I already insisted that in adolescents, you don't take recourse to ultrasound till 8 years of gynecological age. TVS is probably preferred in sexually active women, as women are invariably obese, and follicles 20 or more arranged in the periphery of ovary in a pearl necklace-like pattern. Earlier it was 12, but now the number is 20s. And follicle number per ovary, FNPO, appears to be the most sensitive and specific ovarian ultrasound marker. The second one is ovarian volume more than 10 ml. Oh, and then, so what are the investigations we will be doing? We said hyperandrogenemia, but then free testosterone, which is probably the best method to diagnose testosterone excess, is usually not done because the assays are not very reliable. We have to do a mass spectrometry or chromatography, liquid chromatography, which is not freely available and it is not standardized too. So probably we can take a total testosterone. And sex hormone binding globulin, we understand is decreased. So because it is decreased, more free testosterone is available for action. But then this need not be actually measured except for calculating the free androgen index. So total testosterone is mandatory. If we want, we can take LH and FSH, that is basal level on day 2 or day 3, probably to demonstrate the tonic elevation of LH, but that is also not important, so because it is not at all needed. DHEAS levels should prompt evaluation, high levels should prompt evaluation of an androgen secreting neoplasm, which can be either from the ovary or from the adrenal. Then we have to do a basal level, day 2, day 3, 17-hydroxyprogesterone to screen for late onset congenital adrenal hyperplasia. And if it is positive, we have to do an ACTH stimulation test. Androstenedione, that can be raised. And thyroid, of course, hypothyroidism can cause irregular menses. It can cause PCO-like picture. Prolactin also 40% will have hirsutism, and this can also cause regular menses. So for the excluding, we have to see. Fasting lipid profile is mandatory, especially if the patient is obese, to know the metabolic component and to know the insulin resistance. It's enough clinically if we see acanthosis nigricans, which is seen in the intertriginous area as well as in the neck as a thick and velvety lesion. But ideal would be an oral glucose tolerance test, where so many times impaired glucose tolerance is seen, and type 2 diabetes is also noted. ALT and AST to screen for non-alcoholic steatohepatitis, especially if the family history is positive. So what are the goals of treatment? So one is management of irregular cycles. 2 is amelioration of hyperandrogenic features. Then she has infertility, so ovulation induction for that. Management of underlying metabolic abnormalities and prevention of endometrial hyperplasia and cancer. So let us talk about menstrual irregularities. So in an adolescent PCOS, I told you it's enough if she has irregular menstrual bleeding and hyperandrogenemia or hirsutism, clinical hyperhirsutism. So this can be post-menarche after 1 year. The average cycle length should be more than 90 days to say that it is infrequent AUP. And if it is after 2 years, it should be more than 60 years. And after 3 to 5 post-menarche years, it should be more than 45 days. So the main stay of treatment is for this chronic anovulatory cycles is combined oral contraceptive pills. Progesterone is a critical ingredient in COCs that inhibits hyperplasia that results from unopposed. Either combined oral contraceptives can be given, or progesterone, synthetic progesterone or dihydrogesterone are administered in the second half of the cycle. So every 2 to 3 months, the girl is taught to have withdrawal bleed by taking progesterone for about 10 days. That itself will prevent endometrial hyperplasia. And because of the excessive menstrual bleeding, that results in anemia. So that also has to be corrected. So the combined oral contraceptives have a lot of beneficial effects in PCOS, suppression of FSH, stabilization of endometrium, potentiation of progestin action, and increase in sex hormone binding globulin. So that itself will decrease the androgen, and it also decreases free androgen. Progestin, on the other hand, causes inhibition of LH surge. It decreases in ovarian androgen and estrogen secretion, and it increases SHBG concentration. So what is the preferred COC? So various preparations are available. Anything can be used. Lowest effective estrogen dose, 20 microgram would be ideal. First and generation progestins for acute menorrhagia, and third and fourth generation progestins regularizing, but this can be interchangeably used. Earlier, we used to talk a lot about cyproterone acetate because it brings down the hyperandrogenemia. But then guidelines clearly state that 35 microgram ethinyl estradiol plus cyproterone acetate should not be considered first-line PCOS due to venous thromboembolic risk. And CP with third or fourth generation progestins like drospirenone are preferred for the control of acne. So how do we actually evidence hyperandrogenism? So one is acne, and second is hirsutism, where we actually assess it by modified Ferryman-Galloway score. So actually a score of 4 and more would be very relevant in certain ethnicities like Japanese, Chinese. But for us, a score of 8 and more would be much applicable. And alopecia is by Ludwig visual score. These dermatologists are very proficient in that. And for acne scoring system, we take both comedonal lesions and inflammatory lesions into account and we score accordingly. So what are the drugs used to reduce androgen excess? So for androgen suppression, we have the oral contraceptive pills. We have anti-androgens like cyproterone acetate, and flutamide is no longer used because of its liver toxicity. 5-alpha reductase inhibitor, so many times testosterone can be normal, but then the 5-alpha reductase activity is enhanced. So at the peripheral level, more hirsutism occurs. So that can be blocked by finasteride. And we have insulin lowering agents like metformin and Inositol. So what is the treatment? So photoepilation is probably the first line management of localized hirsutism in PCOS. Diode and alexandrite lasers are preferred. And apart from these lasers, topical efflotin is also a good adjuvant. And cosmetic hair removal methods for hirsutism include bleaching, chemical epilation, plucking, waxing, shaving, electrolysis, and laser hair removal. And it is actually ideal to give the patient earlier. We used to start them only on OCPs. Now we start them initially itself combined therapy, OCPs plus anti-androgens. And after about 3 months, then they can go in for laser therapy, which can be actually repeatedly, it can be done. And after some time, the growth itself becomes less. So for acne, we talked about the management of hirsutism. For acne, antibiotic and topical therapies, tetracycline, erythromycin, and minocycline, which are given for a very long time on and off fashion. Anti-androgen therapy, topical non-steroidal anti-androgen, oncoterone acetate, then benzoyl peroxide, and tretinoin. For alopecia, 2% minoxidil with anti-androgen therapy. So the main thing is, here people talk about cognitive behavioral assessment. So probably we have to take psychologists also into our purview. We have to screen for depression, mood, and eating disorders. We have to tackle addiction, smoking, alcohol, caffeine, and food itself is said to be an addiction. So we have to take recourse to that. And coming to pharmacotherapy, anti-androgens, metformin, COCPs, all can be used. But then orlistat is the only thing what we have, which is not very comfortable to the patient. And bariatric surgery can be done even in a late adolescent if she fits into the criteria. If she is morbidly obese, she has a lot of metabolic problems, only then bariatric surgery is taken recourse to. So lifestyle modification is the mantra. Healthy eating, regular physical activity is very, very important. Achievable goals such as 5 to 10% weight loss yield significant clinical improvements. The SMART goal setting is very, very important. Specific, measurable, achievable, realistic, and timely goal setting. So she has to lose weight only gradually, and self-monitoring can enable achievement of realistic lifestyle goals. So what about exercise? So in adults, a minimum of 150 minutes per week of moderate intensity physical activity or 75 minutes per week of vigorous intensity. In adolescents, at least 60 minutes of moderate to vigorous intensity physical activity per day. So every day they have to do. And activity, it need not be for 1 hour, 45 minutes as such. It can be performed in at least 10-minute bouts or around 1,000 steps. Like that, it can be broken and can be done. There are a lot of yogasanas. We are a country which has given yogasanas to the world, and Surya Namaskar, Sukh Bandh Konasana, Halasana, Dhanurasana, Bhujangasana, Padmasana, Naukasana, All these are prescribed for PCOS and said to have good effect. So I already told you about the cognitive behavioral interventions, which are very, very important. Mindful eating. So whatever they eat, they should eat mindfully, reinforcing changes and relapse formation prevention. And energy deficit of 30% is very, very important. So 500 to 750 kilocal per day of energy deficit should be there. That will be there only if the person takes 1200 to 1500 kilocalories per day. But that will depend on the individual energy requirements, body weight, food preferences, and physical activity levels. So the approach should be individualized. The most important thing is emotional well-being should be addressed. So Indian Dietetic Association guidelines for PCOS are protein first. So in each meal, they have to take protein first. Plenty of fresh vegetables in main meals, which will be eaten like a rainbow. So green color, then red color, yellow color. So all sorts of vegetables should be there. Eat nuts, good quality fats. Complex carbohydrates, whole grains like brown rice, whole wheat and millets. Cooking fat, monounsaturated fatty acid like groundnut oil, rice bran oil, mustard oil, 3 to 4 teaspoons per person per day. Avoid trans fat and saturated fats, bakery foods, ready-to-eat snacks. Anti-inflammatory agents like turmeric, cinnamon and amla. Cinnamon tablets are also available. Decrease dietary AGEs, advanced glycation end products, which actually causes inflammation by decreasing animal-derived foods, processed foods, grilling and roasting. And what about dairy intake? People nowadays say everything white is not good at all. So dairy products stimulate insulin growth factor 1, resulting in high insulin levels. Even skimmed milk is said to do that. I was really surprised by that. But cheese products, although they have caloric value, they do not increase the IGF-1. Probably that can be taken. Milk contains growth stimulating hormones, including IGF-1 and dihydrotestosterone, which increases androgens, resulting in higher sebum production and acne. The DASH pattern, that is the dietary approach to systolic hypertension, where more fruits and vegetables are taken, that also improves the insulin resistance, serum high sensitivity CRP levels, and abdominal fat accumulation in overweight women with PCOS. Nowadays, people do intermittent fasting. Is it scientific? So intermittent fasting can be an alternate day fasting or twice weekly fasting. And as Hindus, every fortnight we have all this Ekadasi, which really is one form of intermittent fasting. So periodic fasting, several days every two or more weeks. So different fasting regimes can reduce IGF-1 and insulin growth factor binding protein 1, glucose and insulin levels, and consequently have beneficial effects on ovarian function, androgen excess, and infertility in PCOS women. So many girls have really followed this eating window. So they eat well for about 8 hours, then 16 hours they fast. That really has helped them to lose weight. There are a lot of scientific papers which promote that. What about pharmacological treatment for non-fertility indications? So I already told you that COCP is the combined oral contraceptive is the first thing which we have to use. That really helps in regularization of the cycle, decreases the menorrhagia, and it also decreases hirsutism to a certain extent. And we also have to add lifestyle, as I already told you, anti-androgens and metformin. With actually metformin is said to be an off-label use, although we use right and left. Most useful with BMI more than 25 and in high-risk ethnic groups. So probably for us, even at 23, we can start using it. But then there are a lot of side effects, including GI effects, which are dose-related and self-limiting. Start with 500 milligram, Maximum dose is 2,500. But it appears safe long term, but then we have to add vitamin B12 when we are giving. So metformin has been in use since long for PCOS. Now inositol is emerging as the new therapy. So it is essentially an off-label use, cannot act alone, can be given with COCs or gonadotrophins, but most important thing, it prevents OHSS, not recommended for weight loss, does not prevent pregnancy complications of PCOS like GDM, preeclampsia, preterm or miscarriage. So is inositol effective in the treatment of PCOS? Myo-inositol and D-chiro-inositol, they are all nutritional supplements that act as second messenger and play a role in insulin signaling transduction. The emerging data suggests metabolic, hormonal and ovulatory benefits. And inositols actually increase insulin sensitivity and glucose utilization. Combination of metformin with myo-inositol and D-chiro-inositol that causes significant improvement in insulin resistance, better restoration of menstrual cycle, significant improvement even in weight loss, and significant improvement in hyperandrogenism. So it affects all facets of PCOS favorably. So we are coming to infertility management, because that is one big bugbear what we have. So the H3ASRF International Evidence-Based Guidelines 2018 clearly state that letrozole scores over clomiphene citrate. So that is the message is very clear. So that is the first agent, and then metformin can be added to clomiphene or letrozole, and gonadotrophins are only a second line. They come later only. We add them only later, gonadotrophins, and they still talk about laparoscopic ovarian surgery is indicated in certain specific patients, and only after all these fail, probably we have to take recourse to IVF. So I told you letrozole is the preferred ovulogene, and low dose step up or step down regime of gonadotrophins is the next option. OHSS is seen in about 10%. Metformin decreases it. Cabergoline also as a dopamine agonist helps in its prevention. In IVF, it is always, we do not do fresh cycle. It is a segmented IVF. So stimulation is done in one cycle, then freeze all, and then after that, embryo transfer is done. Antagonist cycle is preferred with agonist trigger. Cochrane recommends in vitro maturation to be better in PCOS. So we have talked about all these infertility. Then coming to contraceptives, coming to role of oral contraceptive pills in polycystic ovarian syndrome prior to ovulation induction. So routinely that is what is being done, but then the strength of evidence is very low. And before induction, it is very important to optimize weight. And suppose if the patient has had bariatric surgery, we have to postpone induction after stabilization of the rapid weight loss phase. That will take about 1 to 1.5 years. Strict control of sugars is important. Treat hypothyroidism and hyperlactemia prior to induction of ovulation. So what is the role of ovarian drilling? So it should be taken only as a last resort. Acts by reducing intrafollicular androgenic milieu. Limited role in improving ovulation. No role in improving insulin resistance. And we all know about the 40 watts, then 4 punctures only, and 4 millimeter depth. Cooling of the ovary should be done. But then it reduces increased risk of adhesions. So the patient has become pregnant by our infertility management, and then we understand that pregnancy complications like spontaneous miscarriages, gestational diabetes, gestational hypertension, and neonatal complications requiring NICU admissions are higher in pregnant women with PCO. So it is essentially a woman with PCO is a high-risk pregnancy. So we have delivered the woman. What about the contraception? So OCPs can be given, and then progesterone only contraceptive pill or levonorgestrel containing IUS can be used in PCOS women where the use of estrogen is contraindicated or when androgen excess does not exist. So especially if they have some contraindication to estrogen later because of a previous history of VTE, then probably this can be. So depot-medroxyprogesterone and etononorgestrel containing implant should not be used in women with PCOS, but then the strength of evidence is very low. So I told you about depression. So women with PCOS have impaired quality of life and higher rates of depression and anxiety. However, efficacy and safety of antidepressant therapy is not yet established. This we should know as gynecologists. Obstructive sleep apnea is highly prevalent in women with PCOS, and this has adverse cardiometabolic consequences. So in young obese women with PCOS, successful treatment of OSA with CPAP improves insulin sensitivity, decreases sympathetic output, and reduces diastolic blood pressure. So it is our bounden duty to think about it and refer the patient to a sleep physician. Non-alcoholic steatohepatitis is increased in women with PCOS. Weight loss and metformin improve metabolic and hepatic dysfunction. So what about the long-term consequences of PCOS? So generally we always thought that there is greater odds for elevated CVD risk markers. High sensitivity, CRP is always elevated, and this is magnified by obesity, and incidence of preeclampsia is 4 times higher. So her chances of developing hypertension becomes also more, and significant risk factors for developing atherosclerotic conditions, hypertension, and myocardial infarction are present at an earlier age in women with PCOS. And more than 20% of obese women with PCOS have IGT, impaired glucose tolerance, especially after the age of 30, and prevalence of type 2 diabetes in women diagnosed with PCOS is 7 times higher than controls. So insulin resistance with abdominal obesity accounts for the higher prevalence of type 2 diabetes in PCOS, and there is also increase in prevalence of venous thromboembolism in PCOS as a function of age. So as age advances, they have more chances to develop venous thromboembolism. But then Roger Lobo and Carbina, they are all authorities who had worked for long on PCOS. So he has been associated in all the recommendations from NIH, then Androgen Excess Society, then 2018 guidelines. So for 25 years, he has been associated with that. He has published a paper in 2018. Is there really increased cardiovascular morbidity in women with PCOS? He says that there is no increased risk unless she's obese or diabetic. And this is seen only in classic patients, that is phenotype A and B. And spectrum of risk is modified by weight and familial or genetic profile. So what about endometrial cancer? Risk is increased 2.74 due to dysregulation of the signaling pathway and progesterone resistance. So it is not only the unopposed estrogen action, but it's also the progesterone resistance. Progesterone related gene GAB1 is decreased in the secretory endometrium in PCOS. What about ovarian cancer? Ovarian cancer risk is increased as per CASH study, and odds ratio is about 2.5. But the one good thing is it is higher in never users of OCs, and probably if they are taken combined oral contraceptive pills, it need not be that high. And we always think because these patients are obese, hyperinsulinemic, and their insulin growth factor activity is also high, they might have increased chances of developing breast cancer. But all studies to date show no increased risk. The odds ratio is only 0.88. Why somebody is, somebody is actually, so the metformin decreases breast cancer risk. So that is one important thing which we have to think. So that is about 20%. What about menopause? Women with PCOS enter menopause later, but then hyperandrogenemia persists, hirsutism persists, so they are really hairy even in menopause, but then it is decreased to a certain extent, less menopausal symptoms, but more vaginal dryness, lower prevalence of hypothyroidism, but insulin resistance increases with age. Now coming to dogma theory of PCOS. What is dogma theory? Dysbiosis of gut microbiota. So this is actually because of high sugar, high fat and low dietary fiber diet, which invariably is the diet of women with obese women with PCOS. This creates an increase in gut mucosal permeability with a resultant increase in the passage of lipopolysaccharide from gram-negative colonic bacteria into the systemic circulation. So the immune system is activated, which interferes with immune receptor function, driving up serum insulin levels, which increases ovarian androgen production and interferes with normal follicle development. So what happens in PCOS? The stool microbiome of PCOS patients showed a lower diversity and an altered phylogenetic composition compared to controls. So actually the diversity should be more to have a good gut microbe. So I already told you about this high fat, sugar, low fiber diet. So this will cause an imbalance between good and bad gut bacteria. Obesity also will alter the gut microbiota. And then, so because of that, what happens? There will be epithelial integrity will be affected, resulting in a leaky gut. So the lipopolysaccharides which are produced by the colonic bacteria, they pass through the gut wall. So they enter the circulation. The gut inflammation initiated and this enters the circulation. This causes a state of insulin resistance. This hyperinsulinemia drives the testosterone production in the ovary while impairing follicular development. So all three components, polycystic ovaries, then hyperandrogenemia, then anovulation, all these things are actually explained by this dogma theory. Okay, so what do we do for that? So probiotics or prebiotic treatment. So probiotic means it is the curd, that is it contains the beneficial organism. Prebiotic is the food for the probiotic. That is, they say that is more of, what is that, onion, then, what is that? All the lot of things like turmeric. So all these things, they increase the number of beneficial good bacteria in the colon. And this beneficial good bacteria will produce short chain fatty acids. So that will actually cause tight junction formation. So because of that, bacterial lipopolysaccharide cannot enter the circulation. So there is return to normal ovarian function. And because of all these things, there is increased production of the satiety hormone GLP-1 by the healthy colon mucosa. That also reduces food intake and results in a decrease in body fat component. So many nutritional supplements are also said to be good. N-acetylcysteine, then vitamin D3, fish oil, and vitamin B12. And coming to the effect on the child. So PCOS is associated with elevated prenatal testosterone. That I already talked to you about that earlier. So prenatal sex steroid theory hypothesis that women with PCOS would have heightened autistic traits and an increased rate of autism among their children. They themselves have some type of amount of autism, and there is increased rate of autism among their children. There are a few papers on this. So to conclude, PCOS is a multifactorial heterogeneous disorder affecting the women of reproductive age. Genetic, neuroendocrine, metabolic, environmental, dogma, and lifestyle related factors are known to cause PCOS. High prevalence of PCOS in adolescent and adult females, and most of the time it remains undiagnosed. No USG for diagnosis of adolescent PCOS up to 8 years of menarche. Rotterdam criteria for diagnosis of adult PCOS. AMS should not be used for diagnosis, although a cutoff of 4.7 has been proposed. Serum insulin need not be measured. Treatment should include lifestyle modification, physical activity, yoga, diet, pharmacological interventions. These pharmacological interventions can be done as per the algorithms recommended by H3 ASRM 2018 guidelines. Insulin sensitizers like metformin and inositols are efficacious and safe. Depression and anxiety to be taken care of. Combined OC pills is the first line therapy. Progesterone withdrawal for menstrual irregularity and cancer prevention can be done once in 2 to 3 months. Metformin is very useful when there are metabolic features, may be continued in first trimester, although the final say has not come out yet. Letrozole is the first line for infertility, and caution must be exercised prior to induction to avoid OHSS. Gonadotropin second line in infertility, and PCOS has poor pregnancy outcome, both maternal and fetal. Long-term consequences of PCOS include metabolic, cardiovascular, and cancer risk of autism in the children of PCOS women, and triennial screening for metabolic syndrome after 35 years. That is very, very important. And a woman has GDM, she should be accordingly investigated for onset of diabetes. If she has hypertension, she should be looked for it. So it is very important that PCOS, which is actually imprinted in utero, has effects up to her last life. So thank you very much for the patient here.
Thank you, Dr. Shanti, for a wonderful information on this topic. It was really nice. Dr. Sumati, are you here? Yeah. Dr. Padma, would you like to say anything?
Yeah, madam, as usual, your talk is very excellent and we all enjoyed it. And the very way you started the talk saying there's a disease from the womb to the tomb explained everything in just one line what PCO is about. And there are a lot of messages coming in that it has been an excellent talk. Dr. Revati madam also has put in a comment. Charmila also is there and she has also put in a comment. And some of the pearls which impressed me were the answer to the disease being in the intrauterine life, because now they're saying all the lifestyle disorders, the origin is in the intrauterine life. So PCO also comes under that. And the second important thing is when you need to investigate a girl for PCO with an ultrasound, because time and again we see, which is in just 1 or 2 years of menarche, girl coming with an abnormal bleed and then ultrasound showing PCO, and then she gets labeled, and that label sticks on to her for life. So all these things you have beautifully brought out, madam. And the more important thing is about the psychological aspects, like how to motivate them for a weight loss and what kind of diet, and then asana not only helps in the treatment of PCOS but in the long-term well-being also, which is very important for a patient with PCO, considering her long-term chance of going in for medical disturbances. And the DASH pattern of dietary loss, and apart from that, the pharmacological treatment like metformin, inositol, a combination is much better than any individual one. And the other important thing is about the obstructive sleep apnea, which we all know is a very important component for many of the lifestyle diseases like diabetes, hypertension, and which is an important component for women with PCO also. And the other important thing I noticed was about the prevention of malignancies, how OCPs in a PCO girl, I mean, regularizes the cycle, plus it prevents ovarian cancer also. And the dogma theory, the use of both prebiotics and probiotics. A beautiful presentation, madam. And I think there'll be a lot of questions coming in from our participants today. And I see quite already a few in the chat box. Madam, would you like to answer the questions or should I read it out for you?
Oh, okay. I can see. I just see. Okay. What are the investigations that would be advised initially for a girl presenting with signs of PCOS? So the most important thing is whatever it is a diagnosis of exclusion. We take it as that is with just menstrual irregularity as per her age. We decide. Then hyperandrogenism. So that also is very, very important. So hyperandrogenism, especially in this patient, we have to rule out non-classic congenital adrenal hyperplasia, which can present at this age for the first time. So it is very important to do basal 17-hydroxyprogesterone, then DHEAS, total testosterone, androstenedione, and in our ethnic group, we have to rule out diabetes or even IGT by doing a 2-hour OGTT. So, and a BP is mandatory, waist hip ratio, so that we take after 3 or 4 months, so that will also be encouraging for her. And when she starts losing by a size or 2, that itself will help her, that will motivate her to lose to persevere with her weight loss. So for all these things is very important, and we have to insist. So all these tests, lipid profile is also very important in our ethnicity. So all these tests have to be done. Thyroid, prolactin. So it is ideal to do a complete investigation at the first thing. After that, if everything is fine, we need not repeat it much. And serum insulin need not be measured at all. That we are very, very clear. The only thing is clinically we can make it out by acanthosis nigricans. 2-hour OGTT, that itself would suffice. No need for insulin at all. Fasting, postprandial, all that. And this cheese better than milk. See, this is the guidelines by Indian Dietetic Association. I spoke to one of my dietitian who is really extremely good, Mrs. Meenakshi Baja. She's very good. She's in Omandura, and she's a very active dietitian who really is very knowledgeable. And only after confirming with her, I put this up, because the caloric value of cheese is still there. But then, if you really want products, milk products, cheese is better than milk. So I wanted to, with this message, to go across. And there are a few papers I went through that.
The cheese is a very good protein also, right?
Yeah, yeah. So even for lean PCOS, it is very important. That is, we always talk about the YY paradox. That is, we Indians, we actually have more subcutaneous fat. So even people who are lean and like very lean people, they have more subcutaneous fat, which is metabolically active. So even for lean PCOS, we have to stress on the importance of exercise and weight loss to a certain extent. AMH actually, there are a lot of papers which are coming around that cutoff of 4.7 probably tells that it is PCOS, but then that will help us more for fertility. And LH also, if it is tonically elevated, if it does not respond with all our conventional ovalogens, then probably here comes the laparoscopic ovarian treatment. So for infertility, probably we will be doing. Metformin can be given in lean PCOS. That's what I'm saying. Use of metformin itself is off-label. That is what, when I went through all these recommendations, I came to know. But then, since there is insulin resistance, as an insulin sensitizer, it can be given. Any other questions?
There are a few on the chat box, ma'am.
Yeah, I've seen.
See, I'll just, I'll let you know.
What is the effect?
Somebody...
GIT means what? Gut? See, what happens is, in dogma theory, what they say is, that is normally in colon we have certain bacteria. These colonic bacteria are beneficial, which need to be there. But then if these colonic bacteria are affected, then they can release lipopolysaccharide, which can actually disrupt the epithelial integrity of the bowel wall, and it can enter the circulation. So because of that, what happens? Insulin resistance is said to increase. That will initiate insulin resistance, and that results in all three manifestations of PCOS.
Ma'am, I have a question. Can I ask you?
Yeah. Please.
What is your say on using this progesterone intrauterine device for prevention of endometrial CA for these women with PCO?
No, I really feel it is very, very good, because now I think that has really, we don't seem to do hysterectomy so much now with all these things. I really feel this is very helpful, and people talk about putting this even for early endometrial cancer. That I'm very scared, because sampling is so difficult with the LNG-IUS inside. I find it very difficult. But then I really feel this has really reverts the hyperplastic pattern into normal HPM, histopathology.
So do you think it will be a better form of contraception, considering the fact that OCPs, they have a higher instance of VT in this group of women?
Yeah, it can be. So that is why I put up that levonorgestrel IUD can be given safely, which is really very helpful. So that is there.
And actually, Charmla has asked a question. Is there a role for SCRM like ormeloxifene in AUB due to adolescent PCOS?
No, I do not know much about this ormeloxifene, although it is being produced here in India. So we really think it is our Indian product. But still somehow this ovarian cyst formation, all that is more with benign cyst. But then when it occurs in ovary, you get tensed up. So I'm not for ormeloxifene. That's what I would say.
See, even I am so, madam, I'm not a big fan of ormeloxifene. So no, probably I think we need more research papers. Yeah. Being an Indian product, if some of them take up it as a thesis project or a research, then we will get more information on this.
It seems to be very effective. Many practitioners, I see them using lot of ormeloxifene. But then when people come with the ovarian cyst, actually when we stop it, then after that we withdraw. By 6 months it goes down. But that it causes lot of anxiety. That's what I feel.
I think Charmla wants to say something.
Yeah. Madam, when we studied in Bombay, we did lots of studies on ormeloxifene in adolescent DUB. AUB, we didn't do it for PCOS. But for a short time of period, because some mothers are very anxious about giving OC pills for AUB in adolescents. They have a negative thinking about OC pills. So when you give for a short period of time, like for a 3 months course, they usually alter the profile. And suppose if you counsel her properly, they lose weight and they sometimes return to the normal pattern. For a short time, ormeloxifene was good when we were using it.
There are certain papers from India actually. So what you say is correct only, but then
it's got a negative connotation for certain group of women. They don't want that.
Now I think people are very open. If you sit and counsel people, See, we used to talk about OCPs, parents not agreeing to that. But now they understand, we tell them they have all these effects. So it's not only for contraception. So, but what you say is very correct, Sharmila.
Wonderful talk, madam. Very nice.
Thank you.
So loose it is, comprehensive it is.
And there are a few more questions, but almost all of them seem to have been answered. And are there any further questions from our participants? Mahalakshmi madam, you want to add some comments? You are muted. Unmute yourself.
Madam, in the chat box, you see any extra question, madam?
I don't think so.
Yeah, almost madam has answered all the questions.
Very nice, comprehensive talk, madam. Very
Madam,
nice.
once again, you have proved you are a beautiful teacher. My applause to you.
Yeah. Okay, madam, give a conclusion, madam. Padma, madam.
I don't think there is anything I have to conclude now. Madam has brought out all the pearls of PCO, very much relevant for day-to-day practice. What kind of advice? It was really a beautiful talk, madam. Shanti, madam, thanks. We have heard to so many talks on PCO, but this was something which brought out the important salient features of every aspect of PCO. Thank you once again. It was a great talk.
I enjoyed being with you all.
Thank you, madam.
Thank you a lot, doctors, for being a part of our webinar and coming on board. Dr. Shanti, Dr. Padma, Dr. Lakshmi, even Dr. Sumati, and Dr. Mahalakshmi. Thank you so much, ma'am. And thank you so much, Dr. Shanti, for a wonderful session. Thanks a lot. Thank you, doctors.
Thank you.
Have a good day.
Thank you.
We may log out now, doctors. Thank you.
Oh.